All right, we are live, and big thanks to Dr. Howard for joining me today, so that we can talk about this heel pain thing. I think first off, Kurt, why don't you tell us a little more about your background?
Well, I'm a physician of foot and ankle podiatry, board certified, and I practiced for about 40 years. And probably the number one thing we see is heel pain. So it's a real common problem.
So you've almost had more experience in podiatry than I've had experience in years on this planet.
You're saying I'm old.
No, I'm just saying you've been at it a while. That's all I'm saying, Kurt. So,
Okay.
so
Okay.
the number one thing that you've seen over the years has been heel pain. Why?
Well, I think it has a lot to do with the surfaces we're on. It also has to do with age. I hardly ever see what we call plantar fasciitis, heel spurs, things like that in anybody under 30. You just don't see it. So it's that aging process where the plantar fascia will lose the ability to stretch, and when it doesn't stretch, you get that pulling and tearing. Usually the patient will display this symptom. First step in the morning, it kills me. It's like I'm stepping on a knife or something. And after I walk a while, it leaves off. That's because the plantar fascia will then stretch out. So it's almost always first step in the morning kills me. And it's everybody, rarely under 30 years of age.
So, what would you recommend as far as like people trying to prevent this from happening?
Well, yeah, it's tough because I'll see skinny people, I'll see obese people, I'll see women, I see men. The only common denominator is age. So it's hard to pick out one thing. I'll see people 350 pounds never have heel pain. See somebody that's 6 foot weighs 150 pounds, he's got bad heel pain. So it isn't always age. Weight. It isn't shoe gear. It's more of a just kind of a. That's why it's number one. It crosses all age groups, not age group, all demographics except for age.
Okay. So what can you do about it when you get it?
Well, from a very simple non-surgical intervention, a lot of times an orthotic will solve the problem. And we have pressure plate analysis that can diagnose the potential for problem. It's called the plantar fascia elongation time. And if we see that approaching over 170, I think it's microseconds or something, then they are in that group that can have problem. And I'd recommend they get into an orthotic to cut down on that elongation time. The next step is cortisone injections. The next step after that is surgery. So if we can diagnose it in the early stages, and someone that has an elongated plantar fascia elongation time, get them into an orthotic, we can save them a lot of problems.
Okay. So are we talking about any orthotic here? Can we go to Walmart and stand on the Dr. Scholl's thing?
No, it isn't really an arch support. It's a functional orthotic, and what we'll do, we'll evaluate the severity of it. We will usually evert the heel a little bit with your orthotic with a medial wedge, and then put a valgus post on the forefoot. So it will shorten that elongation time. So it's very specific type of orthotic. I have had some patients that have picked up something at Walmart, and it has helped them. But I make that analogy. It's like going to the grocery store and going through the different glasses in the box there till you find one. Yeah, that's pretty good. I can see better. or go to an ophthalmologist and get your eyes examined and come up with something just specific for you. So what we make is something very specific for you.
Right. And it's based off of not just standing on a platform, but actually looking at dynamic pressures, dynamic movement, how your body interacts with the floor as you walk through gravity, correct?
Exactly. That's what's nice about a dynamic scan. There's systems out there that where you just stand on it. In fact, you talk about Walmart. They have a Dr. Scholl's thing, and you just stand on it, but it doesn't catch your gait, heel strike, foot flap, propulsion. You need all those part of the dynamic scan to be able to come up with the real pathology.
Yeah, 100%. So my sister is always the first one to get on these live videos and say something. And she thinks she did last time that you were with me too. And she says that she says she's got heel pain, but hers got better when she lost weight, which I would imagine is not terribly uncommon. But for someone like Jen, what we're gonna have to do is find her one of our providers. She lives in New Hampshire, so we're gonna have to find her someone there that can do these dynamic scans. Because for our purposes, we're serving Southeast Idaho here for these to do these scans.
Right. Well, and how long does it take to lose 50 pounds? You know,
right.
Whereas you get an orthotic, the next day you've eliminated the pain. Yeah, I've had patients say, "Yeah, I had this for 2 years now," and why do you suffer? You know, within a day or two, we can get you a custom functional orthotic. You know,
and actually, it takes that long, just a day or two, to get them and to start dealing with the actual the core problem, right?
Exactly. That's why it's so typical. The first step kills me. After 5 minutes of walking, it feels better.
Right.
Plantar fascia kind of stretches out and gets feeling better. Whereas if you get right into your shoe, right into your orthotic, that first step out of bed won't hurt.
Right. And it's actually getting to the core deficit, the actual problem. You develop that because there's a biomechanical issue, which we can correct very quickly.
Yeah, exactly. I mean, unfortunately, some of these do go to surgery, and the surgery 95% of the time is very rewarding. It does. You can go in and physically lengthen that plantar fascia with the surgery, but if we can eliminate that and with an orthotic, you're so much better off.
Right. Solve the problem before you have to get to that.
Yeah.
Well, Kurt, I always enjoy seeing you when you are here in the clinic. It's fun to get with you online as well, so we appreciate it. Unless there's anything else that we didn't touch on, I think we'll wrap it up for today.
Okay. I think it probably it's kind of like having an eye exam when you reach 30. Probably people should come in and just have their feet evaluated.
100%.
So
David Strobel's on with us. I wish David would say something about his orthotic. I know he loves his. But it is something that everyone should. I mean, even kids should be in here getting these checked because if we can offset those problems before they start to happen, then we win. I will say one more thing. I was trying to wrap up too early. From the regenerative medicine standpoint, these are awesome as well because when we see these people with worn out degenerative knees, guess what their gait usually looks like? It's abnormal.
Yeah.
So the old saying or the old song about, the foot bone's connected to the ankle bone's connected to the leg bone, that's your biomechanical chain. And if we're having issues at the feet, then they're going to cause problems upstream as well. So to get these folks to heal at an appropriate time or in an appropriate time and get to do it efficiently, we've got to have them on a stable surface.
Absolutely. There was a study done It's been a few years back, but one of the orthopedic surgeons talking about knee pain said, I treat and cure probably 50% of my knee pain with an orthotic.
Right.
I get straighten out that pressure on the medial or lateral side of the knee with an orthotic, and they don't need cortisone injections. They don't need surgery.
Pretty amazing stuff. I know since I had them. So when I started working here, we did the gait analysis, and your providers were able to point out which foot I was going to have problems with, and lo and behold, I've had problems in that foot. But ever since putting that the orthotic in there, I've had no more problems. And then on the regenerative medicine side of things, I think we skipped over looking at doing shockwave therapy and laser therapy for these as one more barrier between, keeping things as conservative as we possibly can going to surgery. We've seen and we've read the papers about shockwave and laser also helping with these tendonitis and tendinosis issues. So there's a lot of options that we have.
Yeah. There's we have many arrows in our quiver.
Absolutely.
Sometimes you go to a doctor that does a heck of a lot of surgery. He's probably got one or two arrows in his quiver. Nice thing about our clinic there is we do have many options. And that shockwave, I had it on my leg where I had kicked into a table, and that was not getting any better after 3-4 months. And it took about 3 treatments. Well, the very first treatment, it felt better. And after 3 treatments, it was completely resolved. So that shockwave's pretty impressive.
Yeah, it's amazing. Amazing technology. I'm glad we are where we are today.
Yeah.
All right, Kurt. Well, thank you very much.
You bet. Thanks for inviting me.
Thanks for everyone for joining on with us, and we will see you on the next video.
See you later.
Thank you.
Bye.